So it is week 7. As I said, your exam grade should be out about 9:30 tonight. Going to get that done and over with. If you didn't hear me earlier, there is no quiz next week. Gives you a little bit of break. It's going to be on week 9, and it will cover week 8's information, which is GI and GU. There is a matching with the GI and GU. Go through it. It goes through the book, exactly all of the topics, all of the diagnoses, and you're going to see some things that are just really specific to the pediatric population. So I would look at that. You do have your pediatric assessment assignment due next week. Do it as much as you can. Remember, you need an approval of the topic, making sure that I just don't have all of one topic, that, the topics are spread out. So far, I'm getting some pretty nice ones. Now, what I suggest you to do, when you do a component of that assessment, make sure, just go ahead, send it in through the modules. You can unlimited submit them. I can be able to see if there's a plagiarism on it, where I can say, hey, change the words up a little bit here and there, or I can see formatting problems. I can help you make it a perfect project, and it's 6% of your grade. That one 3-section project is worth as much as all your CJ Sims. So it is really important to try to get the best grade you can, okay? So send it in as you get my approval. I'll give you little tips what to do, back and forth, okay? And look at the comments in the modules under that, okay? And that's where I put all your comments. So it'll be in the comments. So let's go ahead. Let's get the Kahoots. It's 48 questions. So it is this week's information. So we're doing endocrine and we're doing cerebral. And there are some key things, key concepts, and I believe my Kahoots is going to show them to you. This is your chapter 46 and 47. Anybody have any questions? Remember, as I'm going through this, and I'll be pretty quick, if I absolutely go into it and you're not getting it, please stop me. I can explain it pretty simply in another manner. So just remember, if you don't understand, somebody else doesn't. All right, let's go ahead and get going. Let's see how we are after an exam. Week 7. Now your brains are a little putty right now. Let's see how much we can absorb. Growth hormone is administered by what root? Well, these chapters in endocrine talk about different places of hormones. Pituitary is either fluid or growth. You have your thyroid, which is cognition and growth. Parathyroid, all about calcium. And then your adrenals, all about the cortisol steroids. So you got to figure out where these things are coming from. Now, growth hormone is a subcutaneous injection, takes a lot of commitment by the parent and the child, and they give it to those children who are small. Now that their family is short, you're not going to get taller than that, but that child who is short and you want some more height out of them, and they continue it until they stop growing less than 1 inch a year. So it could be into like age 14 to keep it going. Highest priority for a patient diagnosed with syndrome of inappropriate antidiuretic hormone. Well, that is a mouthful. Inappropriate means it's not right. Anti is against, diuretic is urinating. Too much of against urinating hormone. What would you see? That sounds simple as SIADH is. This is a posterior pituitary. and it measures fluid volume. The other side, where you get rid of too much, is your diabetes insipidus, and they're opposite. Fluid balance, always remember, intake, output, daily weights. Those are the three things that you're going to do. Too much, fluid restriction, salt restriction. Okay, so too much, that you're holding in, not urinating. So just remember those little concepts there. Which of the following are signs and symptoms of an inappropriate antidiuretic hormone? So what would you see? An inappropriate against urinating hormone, what would you see? What you would see is no urine output or very little. You'd see weight gain, and you would see that the intake's more than output, all of those things. What is important to cover when teaching the family about prolyl thyrosil? It's also called PTU. It's used for hyperthyroidism. That means too much thyroid hormone is being delivered to the body. So this blocks. Now, there's a specific side effect actually, there's two of them for hyperthyroidism that we use, medications, and it causes leukopenia, which means a decrease in white blood cells. You don't have white blood cells. What do you see? You're at risk for infection, fever, etc. So if you had a fever, sore throat, you'd be calling the doctor, letting them know. A multi. An initial sign of diabetes insipidus. It's the opposite of SIADH, syndrome of inappropriate antidiuretic hormone. Now, diabetes tends to be something that nurses look at and always think that it's sugar. This has nothing to do with blood sugars. It's only about fluid balance. There are two symptoms of diabetes insipidus, and that's drinking too much and urinating too much. Now, diabetes mellitus, drinking too much, urinating too much, but you're not getting your carbohydrates, so you're eating a lot. You're trying to get your nutrition. So those are three P's. Be careful. It is a question that you will see over and over again. Diabetes insipidus is two things: drinking and urinating. Remember, only fluid balance. A multi. What are the clinical manifestations of juvenile hypothyroidism? Now, adults and children with hypothyroidism have all the same side effects except one thing. What makes children different than adults? They're still growing, right? And also, young children need the hormone for cognition. So children not getting enough thyroid hormone would be small, underweight, and cognitively, they're not going to meet any developmental milestones. At birth, another thing that you see with hypothyroidism is constipation. So it'd be one of those things that would be checking for with no stool. So dry skin, constipation, cold intolerance, but decreased growth. A child had a simple febrile seizure. What education would you provide to parents? Now, usually febrile seizures are 6 months to 6 years and they grow out of it. And it happens because the temperature goes from normal and 20, 30 minutes later, it's 101, 102. It's called the rate of rise. Seizures, all the nursing care we have during a seizure is safety. Safety, safety. Turn them on their side. Clean the bed or wherever they are, free from anything sharp. Put their head of their bed down. Have suction at the bedside, side rails up, and just monitor the time. And of course, you're going to call help in there if you're in the hospital, but the time and what the seizure looked like. So safety, safety is what we teach. What type of seizure is when the body's jerking, foaming at the mouth, and the child is rendered unconscious? The most severe of all of the seizures, would you say, is this one? And of course, our names have changed from grand mal to a tonic-clonic seizure. We used to have petite mole, grand mole. Some books you still see it, but our book is tonic clonic. That's the one. And also you might be incontinent too of, either bowel or bladder or both. What notable sign may indicate increased intracranial pressure in an infant? There's many reasons why you could have increased pressure. Most of the time with infants is hydrocephalus. In older kids, it might be a fall and it's causing it, but usually the infants is what we think of. And one of the things that you can hear from a neuro infant, we used to call them, it's their cry. It's different and it's higher. And you could walk into a room of crying babies and go, "Oh, that kid, something's wrong neurologically." You can actually hear it. Now, it's not bulging fontanelle when crying. It's at rest. That means there's too much pressure. All babies will have a bulging fontanelle when they're crying. So it's when they're at rest, sitting up, no reason for it to be bulging. But very good, you picked fontanelle. All of the following increase intracranial pressure except what? Nursing care, we do a lot of things. We have a child with increased intracranial pressure. What do we know so we don't overstimulate and increase that pressure, right? Vital signs has nothing to do with your increased intracranial pressure. Think about suctioning. You stick a tube down the throat, you gag them in the back. They're going to choke. Their pressure is going to go up. One of the biggest things we watch is intake and output. We don't want to get too much fluid because that will cause it. And of course, coughing does. What findings can alert you to a head injury's getting worse? How many children come in after a sports injury or falling off something and they said the child was knocked out? And what do you always hear with these kids? They're playing ball and was I safe at the base? Did we win the game? Where are we? And it gets even more and more. It's that amnesia that happens, but it gets to the point where now you can't wake them up. And now we know our head injury is even worse, probably need some sort of evacuation of a hematoma. So it's the LOC, change in orientation. A multi. What does it mean when you see a fixed and dilated pupil after a head injury? I think one of the first things as medical professionals we do when we know a child has fallen off or out of a balcony or we know that they have head injury, we always look at the pupils. And pupils will tell us, is there any neurological damage in there? If it's fixed and dilated, you've got brainstem injury going on and it needs immediate attention. That usually will mean many of these children are going to have a decreased quality of life from now on. So greater than 5 minutes, we know brainstem, that's your center, the computer centers, heart rate, vital signs, it's everything. So that is something that we watch very, very closely. So pupil checks, right? What medication may be used for a child with cerebral edema due to a fall? We have diuretics we use for a pulmonary edema, peripheral edema, right? But there's one that we use specifically for increased intracranial pressure due to cerebral edema. Now, it can be used for renal failure and toxic ingestion also. But this is something that we give mannitol, and immediately you'll see fluid just start coming out, specific to the brain. Reye syndrome. What do we need to be worried about that for? What's Reye syndrome? So Reye syndrome is when you give a child less than 8 years old, give them aspirin for a fever or just normally instead of acetaminophen or ibuprofen. and it can cause a lot of problems with the organs in the body. So, unless they have Kawasaki disease that we learned in the cardiac week, right? We don't give aspirin to children normally. If you ever hear a parent say, "Oh, I'll medicate with aspirin for fever," you would say, "No, this is the better choice," and we don't. Okay? Febrile seizures usually occur in what? How old? How young? 6 months, 6 years, and then they usually grow out of it. My oldest grandson had one febrile seizure, never again, and none of my other have ever had it. Childhood hypopituitarism results in which condition? Now, again, this is anterior pituitary and has to do with growth. Hypo is less than you should. So we're going to see pituitary dwarfism. We also have hyperpituitarism, and that's gigantism. That's the 8 foot tall person. Many a time, it's actually a tumor on the pituitary gland. How would you describe precocious puberty? And it can happen in boys or girls. And if we're going through it, there's actually something called Lupron we can give to stop the puberty. But what happens is they go through puberty early. This is a 6-year-old getting breasts. This is a young 7-year-old boy getting facial hair. So these children don't need to go through puberty that early. Can you imagine the teasing that would be going on? So Lupron, it. A multi. What lab values are important to monitor with a child with congenital hypothyroidism? Which ones are the thyroid hormones? Excuse me. T3, T4, TSH. That's all thyroid. Growth, again, is anterior pituitary. Cortisol is your adrenal. How can you monitor a child with hypo or hyperthyroidism? What's things that we always do to look for kids for many, many, many different reasons? Remember, thyroidism has to do with growth, right? Height and weight. It's one of the reasons why we do a height and weight with every visit, whether they're in the ER or a doctor's office. We want to see, are they growing right? Because we can find maybe they do have a lack of thyroid hormone. We can replace it. What acid base alteration would you see in a diabetic child with Kussmaul respirations? This is DKA. And these are those long, fast, just breathing type, very unusual type of thing. And why do we do that? Well, the body is pretty neat. The body is in metabolic acidosis. So when the body wants to correct it, they don't go metabolic, they'll go respiratory, the opposite. And if they're acidotic, they're going to go alkalotic. So respiratory alkalosis is trying to compensate for it, okay? I have seen up to 4 acid-based questions on the HESI. And so it's something that I try to go over and explain to you. I'll even do some more on week 8 with GIGU. A multi. What would a child with Cushing syndrome look like? Well, I'll give you a hint. This is the adrenal gland. We have Cushing's and we have Addison's. Too much, too little. What does the adrenal gland all about? Cortisol, aldosterone. It also has to do with giving steroids orally. And what happens is with Cushing syndrome, they just look with these big round faces. They get these red, like it's ruddy, but it's like this red type cheeks going on. Hairs on the chins, acne will be going on. The trunk, the face will be pudgy. Usually the arms and legs will be thin. And when we have Cushing syndrome, usually due to too much steroids, remember, they're never just stopped. You have to taper them off very slowly because you could go into a crisis, and the treatment actually is give some steroids. A multi. You walk into a room, a child with 104.6 fever, and you see them having a seizure. What are you going to do? Walk in a room, kids having a seizure. They have a fever. So remember, anything to do with seizures, it's always about protection, safety, safety. Turn them, clear the objects, side rails up, pat them, and of course, monitor what's going on. Autoimmune disease of the thyroid gland. Now, one of the things with autoimmune disease and thyroid, it just means you can't do surgery on it because you have to have it there. What does that autoimmune do? It causes a lack of thyroid hormones. Usually, these are young girls, late school age to early adolescence, where we find it. And they're going to need more than one type of hormone, thyroid hormone, and it needs to be monitored really closely. It's called Hashimoto disease. Addison's diseases. Well, we did Cushing's, right? This is the opposite. I call it Cushing's because, like the Pillsbury Doughboy, right? You could push it like a cushion, so everything is big. So that's Cushing. Addison means you need to add something. You need cortisol and aldosterone. A lot of times, Addison disease creates a child that has ambiguous sex organs, and you need to assign sex. And these children will need cortisol and aldosterone for life. Okay, that is the opposite of Cushing's, and it's an adrenal problem. A multi-select, a ventricular peritoneal shunt, the ventricle in the brain, and your peritoneum. And it's that little tube there that goes into that ventricle, goes down behind the ear. You're going to see like a little pump there, and it goes down the front and into the abdomen to the peritoneal sac. It's used for too much water on the brain, hydrocephalus. That pump is only there for the neurosurgeon. We do not touch it. Our job, nursing care, is to measure the head once a shift and measure the abdomen. Is it too big, too small? Side effects. What happens if it's not working? You're going to get pressure in the brain, and older kids come in with severe headaches and vomiting. And usually they need to have their, it's disconnected or they need it replaced because they're growing. The shunt's too small. A common sign of Graves' disease includes blank or protrusion of the eyes. And this is hyperthyroidism. And it's called exophthalmos. Ever see that commercial on TV with that lady wearing the sunglasses and then she starts using the eye drops and her eyes do, you can see them get smaller. A multi. Hypoparathyroidism has the symptoms of tetanic muscle contractions and blank. Well, whenever you talk about muscle and contractions, two of your electrolytes you need to think about is calcium and magnesium, always, okay? The thyroid gland is all about calcium, the parathyroid. has nothing to do with the regular thyroid and those hormones. So the parathyroid regulates the calcium in the body. Too much, too little creates different things. So not enough, your muscles are going to be weak. They're not contraction, right? And of course, low calcium levels. A multi. What are signs of hyperparathyroidism? So too much calcium, right? What would you see? What would it do to the muscles? Nausea, vomiting, confusion, and paresthesia. It gets so overstimulated, it's just there. And of course, the muscles in the brain, you're just almost tonic. It just you don't know what to do and how to do it, and then you're nauseous with it. And again, it's hypercalcinemia. What does the parathyroid hormone do again? So again, the parathyroid is all about calcium, okay? And it's right next to the thyroid gland, but it only has to do with calcium in the body, which has to do with muscles. Which of the following might be a cause of an adrenal crisis? The Addisonian crisis. We a lot of time put patients into this when they have Cushing's disease. Why? And this is when you just stop the steroids and you don't taper them off. And it causes this adrenal crisis. Very dangerous. It feels horrible. And again, the treatment is let's give them the steroids. And then now let's taper it down the way it should go. A multi. Cardinal sign of diabetes insipidus. Explained it earlier. Let's see if you remember. So it's the posterior pituitary gland, and it causes all about fluid. Excellent. Drinking and urinating. Yes. When do you add on the polyphagia? Diabetes mellitus. Good job. A multi. Congenital hypoplasia parent teaching should include, and this is that adrenal insufficiency. This is Addison's disease. You know, in my career, I've only seen one. And this is the child where you need to assign, is it a boy? Is it a girl? Because it literally had a prominent clitoris, it had testicles and a vagina. So what was it? Well, I'll tell you what they did in this case, because I know you're probably wondering. They did ultrasounds and stuff, looked at the body parts that they had. They did hormone testing to see which way they should go. These children will never have babies of their own. They'll be sterile, okay? And they'll require, because of a lack of adrenal hormones, cortisol and aldosterone for life. Again, you're going to regulate it according to stress and growing and all of those things. What causes type 1 diabetes? Is that too much chocolate? So remember, diabetes is when the body doesn't like the insulin cells, the beta cells are destroyed, doesn't produce insulin. Sugar, carbohydrates comes into the body, and the body says, I don't know what to do with you, I can't use you, right? And what happens? You get elevated blood sugars. Now, the body said, I'm still hungry. I need to eat. So then it goes to fat and proteins because it's another nourishment and they can digest that. The byproduct is ketones. So DKA, what do you see? Blood sugars. I've seen over 1,000 on a child. You also are going to see ketones in the urine. And if you do blood gas, which we will, you're probably going to see a blood gas of 7.0. I've seen as low as 6.85, and the child made it. It was an extremely ill case. What statement about a pheochromocytoma is correct? This is one of those tumors that you can't touch, like a Wilms tumor, but not because it is cancerous, but because it's a sympathetic type of organ. And if you touch it, it releases adrenaline and epinephrine, and the body responds, elevated heart rate, elevated blood pressure. It's a catecholamine producer that's on the adrenal gland. Very difficult to diagnose because you're showing cardiac symptoms. So they do a whole cardiac workup. And then they say, all right, let's do a CAT scan of the abdomen, and they find it. So we with nurses are going to be concerned about when they start having those dizzy feelings, chest tightness, elevated vital signs, that we do the vital signs, see what's going on. And they just remove it. So a multi. What action should a nurse implement in the care of a patient with a pheochromocytoma? So again, no matter what, normal movement's going to cause these things to go on. So we're watching vital signs, blood pressure and heart rate. Has nothing to do with blood sugars, nothing to do with fluid balance. A multi. Nursing care of the unconscious child should include so you have a kid who's unconscious. We're going to do all the normal stuff. I mean, unconscious, let's say that the kid has fallen, neuro signs. It could be a paralyzed, sedated child. So again, it's those pupils. Always watching the vital signs. And any unconscious child probably has some sort of brain injury, strict I&O. Now, pain control is not our absolute priority. It's more the fluid balance and neurostatus. Are we going to keep them from pain? Yes, we will. But the other ones are the most important on the list. What might you suspect if a child feels jittery, sweaty, and is dizzy? What are those classic signs of? And they're hypoglycemic. Very good. Symptoms of DKA are one of the things I'm going to say is fruity breath. What does it smell like? Take a nice ripe peach, put it in a Tupperware container, put it in the refrigerator, and forget it for a month. Take it out, open it up, and you're going to have this sickening, rotted, sweet smell. That is DKA. It is really distinctive, okay? Yes, ketonuria. Yes, hyperglycemia. A multi. An adolescent with a BMI above 95% has been urinating a lot. What test can you anticipate? What's the doctor going to do? Well, what is a BMI of 95%? That's your obese, right? So this is an overweight adolescent. What causes urinating a lot? What do you have to rule out? So urinating a lot, you're going to, of course, check your urinalysis, but your electrolytes, your potassium to be sure. Pregnancy has nothing to do with urinating. And of course, it could be that hemoglobin A1C. They say in children, In adults, it starts at 6. As pre-diabetic, 6.5, you are diabetic. In children, it starts at 7, where they call it diabetic. It's a little bit higher. Blood sugars starting at 120, not at your 100. So there's slight differences between adults and children. Diabetic ketoacidosis is caused by what? So remember, you don't have insulin, you can't use sugar. Your body says, oh, I'm really hungry. What am I going to do? It says, let me go to what's left, protein and fats. Okay. And then there's byproducts from all of it. What's the treatment of DKA? Immediately, you're going to bolus them with some normal saline. And as soon as you can, you're going to start a slow, constant infusion of regular insulin. We're not going to be given sub-Q anything. It must be that intravenous and regular is what we give, and slowly bring down that blood sugar. And then correct electrolytes. A multi. A child is admitted with a blood sugar greater than 600 with large ketones. What's your priority intervention? What do you need to do? Sort of all of them, right? Almost. So again, start that IV fluids, get it going, and then titrate the regular insulin drip. And then after that, those are your priorities. And then it's the electrolytes that we're going to do. Sub-Q anything, it's not fast enough right now. A diabetic child is complaining of feeling jittery. Blood sugar is 45. What's the best treatment for this child? Glass of orange juice, glass of milk, give them something with sugar in it. And remember, that's going to burn off pretty quick. So make sure they get something with protein, like a turkey sandwich to follow, something like that. But whatever you have at hand, many of the older children have like little sugar tablets that they chew, or they carry a hard candy. Something quick, quick instant, some sugar to get that blood sugar up. Your patients experienced a head injury. What would most concern you? Oh, head injury, swelling. What would you be worried about with that? Yeah, you'll be monitoring level of consciousness for sure. But it can also squeeze that pituitary gland in there, right? And it can affect fluid balance. The decreasing urinary output is what I'd worry. Excellent. A multi. How do you detect diabetes ketoacidosis? So your blood sugars are up, you have ketones in the urine, you have glucose in the urine. You may or may not be dehydrated. We're bolusing normal saline because of the concentration of sugar. We're trying to get it so that it does, decrease and lower that number. Dehydration, yeah, sort of part of it, but not as much as the others for sure. A multi. What would alert you that a child's head injury is deteriorating? I think the biggest one of all of them is that difficulty to arouse, just amnesia. They're getting confused or getting restless. And then, of course, the headache is getting worse. And most likely, they're vomiting now. no relationship to any eating either. They're just vomiting. A child's been diagnosed with bacterial meningitis. What's the nursing priority of care? What does that child need the most? Priority care. How do you treat bacterial meningitis? Well, 24 hours in isolation and give them their antibiotics. We need to get that bacteria under control right now. Very good. What is the primary cause of injury associated with submersion, drowning? You know, living in South Florida, I've seen a few drowning cases in my career. I've seen some good outcomes and some not good outcomes. And many times these kids come in and they're awake and alert and running around the trauma room. Well, the thing with submersion, they have had a moment where water filled their lungs and they had no oxygen. So it's called hypoxia. That's why that's the answer. Many times these kids are already pulled out, they've already vomited, and they're already running by the time rescue comes. They come in because injury with submersion can happen delayed up to 72 hours later. It's also like ingesting smoke. Same concept, submersion. So 72 hours later, they can come up with respiratory distress. And last question, a multi. Which CSF lab results correlates with bacterial meningitis? What would you see? I used to watch, them do the LPs, and I would look number one at the color of the CSF. If it's clear, it's viral. If it's cloudy, it's going to be bacterial. That's the white blood cells that are in there. And with bacteria loves sugar, so it eats it up. So blood sugars are low, and it leaves the protein alone, so they're elevated. Now, decreased red blood cells, you actually shouldn't see it unless they hit a cell in there. It's really not in the CSF, and you're going to have, I've seen up to 2 tumors to count on white blood cells, and that was a very sick child. All right. Number 3, money, money, money. Good job, money. Number 2, Catherine. Good job, Catherine. Number 1 is Jen. Good job, Jen. And Paige, and another Jen. So I am going to be scoring those exams. I'm meeting with the other professors tonight at 8:30 because actually I teach right after this. So as soon as I speak with them, we figured it out. We'll get those grades up for you. Anybody, any questions? When you do your project, please just send it to me. I'll be watching my phone and I can say yes very easily. It doesn't interrupt me getting you all what you need. Anybody who didn't get a 78, please make an appointment to see me. Overall, the grades were quite amazing. So good job, class. You guys are really an amazing class. Have a great weekend.
Hey,
Enjoy.
I have a quick question for
Sure,
you
sure.
that I can ask when everyone else leaves.
Okay, not a
It'll
problem.
just take a minute.
Not a big deal.